all. Good morning. This is the Interventionist here again after a long time. So, I hope you are still watching the contents I have posted online. Thank you for the viewership. Thank you for the subscriptions. So, today I am posting a video which has been presented to the National IRIA of India. And this is a special session done by me for my country, radiology department, and hence I am uploading this for your viewership also. Please continue to watch. Do subscribe. Also note that towards the end of today's video, I put a direct link towards my Instagram account for which I am more active nowadays, because I have very little time for editing and other follow-ups. So if you have any queries, you can contact me in the Instagram handle as well. Thank you again.
Thank you, Sastika and the Klarna team for giving this platform for Kerala IRIA 2025. So I welcome all of you and a big good evening to all of you, to all the delegates who are going to listen to this talk, including the faculties and junior residents. So today we have an expert faculty who's going to talk on imaging liver tumors, Dr. Arif Khan Sainuddin, who was previously a consultant radiologist in Trivandrum, who was working in the hospital in Trivandrum, and now he has shifted to Qatar in Al-Hari Hospital. He is the intervention radiologist, and he has given a lot of talks for Kerala IRIA, National IRA, and ICRI. He's an expert speaker and a faculty for IRA and ICRA. His talk is really very good and will be very useful for the residents who are going to give their exams. So I invite Dr. Arif to give his expert talk for Kerala IRA and other residents who are going to listen to the talk. Over to you, Dr. Arif.
Hi all, I'm Dr. Arif Khan here. It's been a long time that I took a platform for any educational purpose because of busy life schedule and all those things. So most of you will know me as the interventionist during the COVID time, and still active in Instagram as well. So you can join me there. So today, I would like to thank, first of all the organizers of IRA and Clarinet for allowing me this opportunity to present on platform. I'd like to have my sincere thanks to Dr. Gomadi madam and Dr. Deepa for pushing me to do this. Of course, she's the one who made me do this. So I hope I can do justice to all of their efforts. Let's start. Okay, so today I will be going across this topic of liver tumors, imaging in liver tumors. So as you know, it's a very vast topic. So I have customized it in a way that where I felt like most of us radiologists are struggling to or not very familiar with. So bear with me. It's a little bit jumbled, but I will get the gist of it once I start it. So we will go ahead now. Okay. So I think everybody is ready. We will start now. So just briefly about the objectives of today's study. So we will be focusing on various imaging modalities, techniques for hepatobiliary imaging. And we will try to understand the liver-specific protocol imaging in both CT, MRI, especially discuss on contrast. We will discuss on phases and contrast phases. So also we will be discussing about LIRADS and similar classifications, especially in pediatric age group, the applications. So we will try to manage to discuss some tumors, not all. All tumors is not possible given the time frame. Okay. So before we go into the main content, I would like to have a brief histological understanding of the liver tumors. So our liver tissues, the functional lobule, the liver function lobule is composed of hepatocytes and cholangiocytes. So about 80% of the liver mass is composed of the hepatocytes. So this is how it gets aligned. It's aligning the periphery of the sinusoid and the hepatic artery, and all is paired with another lining of bile duct and cholangiocyte. So the importance of this is the presence of hepatic progenitor cells. I'll tell you why it is important. So let's imagine we are starting from the pediatric age group. So pediatric age group itself, when you have a hepatocyte progenitor cell, this can directly transform into a hepatoblastoma similar cell, or it can mature itself to hepatocyte, and it can go for a progenitor like hepatocellular carcinoma, or it will progress to mature hepatocyte and then this can also become hepatocellular carcinoma. So the differentiation is wide. So in general, if hepatocyte undergoes injury, it will repair back and it will form a new hepatocyte using the hepatocyte progenitor cells. But the problem happens whenever we have a genetic change. So genetic changes will remodify this back to hepatocyte precursor, and these precursor cells can have the potential to either go for a hepatocellular carcinoma cells or biliary-like cells and then to cholangiocarcinoma cells, or what normally happens is like it will anyway try to become a mature hepatocyte. So just to show you this, if you are interested in learning more about this is an interesting article. You can just scan this QR code or take a screenshot and later do it Google Lens. You can go to this article. Okay, that's what. So next, we'll go to the next important part, the classification system. So there are numerous classification systems. As radiologists, we need to be focused on certain things. For example, liver tumor, the spectrum of diseases start from childhood and it goes till the adulthood. Or certain tumors are only limited to the adulthood. So the best classification system we should follow is benign versus malignant. In that, histopathological grading is straightforwardly simple: carcinomas, sarcomas, and metastasis. And in carcinomas, the most tumors are adenocarcinomas in the GI system. So I will categorize some of the tumors which we will discuss today as blue and yellow. Pediatric for blue, adult is for yellow. So in the benign tumors, hepatic hemangiomas has both pediatric as well as adult involvement. When we have focal nodular hyperplasia, it's a predominantly adult variant. Doesn't mean that it will not come in pediatric age group, but the diagnosis is usually in adult population, okay, or incidentally picked up in pediatric age group. Then we have hepatic adenoma. Then we have mesenchymal hematoma, which has a variable presentation, but more towards the later decades of pediatric life and early decades of adult life. So when we are discussing about primary liver cancers, hepatoblastoma is the number one tumor for liver in pediatric age group. When we have hepatocellular carcinoma, predominantly adult age group tumor, but you can also see in child of the first decade, like between 5 to 10 years of age, there are reported cases. Then we have intrahepatic cholangiocarcinoma, rarely occurs in child, isolated, and it is more towards the adult population, that too towards the end of the later decades, above 4th, 5th decade. Okay. So now coming to another important part of general imaging consideration. So in general imaging consideration, I would like to highlight some points. Sorry for that. So mainly, see, any screening modality investigation, we have to be sure that we are using the appropriate modality for screening. So I would always recommend everyone to start with ultrasound, even for primary screening, and then for the evaluation on the later phases. The ideal imaging should be ultrasound, because this will give a non-ionizing evaluation method, which you can follow up for later evaluations also. Not just that, if you consider CT, the CT, plain CT has very limited role in diagnosing, also following up or a liver lesion, because in plain CT, a cyst will look like an hemangioma. Hemangioma might look like a liver metastasis, and liver metastasis can look like anything. So there is no characterization. So isolated evaluation with plain CT alone should be avoided at any cost. You can use ultrasound for screening. Then if you find a lesion, go to either CT or MRI with contrast. Okay, in cases where contrast is contraindicated, if you need a modality to be evaluated, use MRI, use all the protocols available for you, use it. So that's the take home. So just remember that. So in the contrast study, again, the question comes whether or what type of contrast study we should use. So in liver imaging, it is always triphasic contrast. What do you mean by triphasic contrast? You may not need to use oral or rectal contrast media if you are imaging a non-liver pathology alone. The advantages being you will get a definite enhancement. There will not be any overlap of the densities from the luminal contrast media. In some cases, it can hamper the densities. So these kind of scenarios we should avoid. So you can use IV contrast studies alone. And in this CT or MRI, the protocols are almost the same in contrast study. You use arterial, portovenous, equilibrium whenever required, and then hepatobiliary phase for specifically for hepatobiliary phase contrast agents, which is applicable currently for MRI only. Okay. Now coming to the imaging techniques and protocol. CT imaging, of course, non-contrast, followed by arterial, portovenous, and delayed phases. The injection doses are particularly standard, 1.5 to 2 ml per kg, injection rate of 2 to 4 ml per second, and followed by saline flush post-injection. The quantity and the dosage, the flow rates, all are depending upon the institution parameters. For example, if you are using you should use a pressure injector, of course. You should use a pressure injector. Otherwise, the correct densities will not reach while just you are doing hand push, it will not reach. Even if you are maintaining the exact times, the density or the contrast intensity you expect will not come. So it is recommended to use pressure injector for both CT and MRI. CT, of course, you have to do with pressure injector only. Now, the thing is, one important thing I would like to share is regarding the flow rate. Flow rate, depending upon the cannula size. So ideally, you should put an 18 gauge needle. If it is 20 gauge, you cannot push more than 4 ml per second in most of the patient. And the position of the cannula. Very often, we have a great amount of argument with the clinicians or the referring nurse or whoever in our hospital even. They put cannula or butterfly in the hand. No, don't do it, especially for children. Don't put any contrast injection through the forearm or hand or anywhere. The ideal location is antecubital fossa. If it is not possible, you can try the other hand, or if it is that also not possible, you can try the lateral veins, like the basilic vein or the cephalic vein. So this is the only recommended ones. The reason being is if you put the cannula in a branching vein, and if you inject a contrast of more than 3.5 ml or 4 ml per second in a 18 gauge or let's say 20 gauge, there is a high chance of extravasation and it cause complications. So whenever you are evaluating for any contrast study, the recommendation will be antecubital fossa. Minimum should be 20 gauge. Ideal is 18 gauge. Use it for safer administration of contrast media. So the phases, standardized, arterial 20 to 30 seconds. Hypervascular tumors will enhance and then wash out in the portovenous phases, 60 to 70 seconds. Delayed is 3 to 5. This is like a equilibrium kind of scenario. In these phases also you will see some enhancement, especially if there is a fibrotic appearance of liver, which will come in the later images. Sorry. And in the late phase, which is optional, when you want to see a late enhancement, especially if you are not using a hepatobiliary contrast media, you can wait for till 15 minutes in some cases, okay, to see the filling up of hemangiomas and something like that. Now, when to avoid CT? If possible, you have a modality of MRI and there is an option for sedation and recovery for pediatric age group. Try to use MRI because MRI will give you more characterization, and the LIRAD recommendation for pediatrics is or Pretext recommendation for pediatric tumors is MRI. Okay, you can additionally use dual energy CT or CT perfusion whenever applicable or useful. So MRI imaging, coming to MRI imaging, the routine sequences are implied. Only thing is we have to use faster acquisition in pediatric age group because of the we cannot control them for too much or too long. They will be moving, and even adult patients sometimes it's very difficult. So we have to adapt the sequences accordingly. So typically what we are using is we will use of course localizer for starting. Then we should use a T2 weighted images, especially fat suppression. You can use a faster T2 blade in any other planes, coronal, sagittal, for your according to your convenience. The most important sequences being is T1 in phase and out phase has to be done. Diffusion weighted imaging can be done and should be done in most cases. Dynamic contrast study with all the phases mentioned earlier has to be done for enhancement, arterial, portovenous, and delayed. And whenever you are using hepatobiliary agents, for example, the most approved ones, even in Qatar here, as well as even in India, we have this hepatobiliary agent is gadolinium disodium. The advantages and disadvantages I will discuss soon. Additionally, we can use MR elastography, also MR spectroscopy for fat ion quantification, but not necessary in these scenarios. So in MRI imaging, the contrast, of course, is gadolinium based. So we have two sets, intracellular and extracellular. The routine ones, the conventional contrast, whichever we use in our department nowadays, is extracellular contrast media. The hepatobiliary phase contrast media, which I mentioned, will be intracellular. Okay, so the dose is 0.1 millimole per kg, and injection rate is 2 to 3 ml per second, followed by 20 ml saline push. And phases are same, arterial, portovenous, and delayed. The one good thing of MRI is that since we are acquiring continuous images, you don't need to, wait and then lose the time. So the moment you inject the contrast, already the machine is taking on continuous images. So this cycle will go from 0 till up to 5 minutes for one set, and then they will image the remaining protocols, and then they will come to the hepatobiliary phase when it is applicable. So this is how they plan the study. Nowadays, the modern machines, all these protocols are by default set in it. So coming to the hepatobiliary contrast agents, I will just discuss today the whole images which I put are based on studies which used gadoxetate disodium, otherwise known as EOVIST or PrimoVist. The reason why these is preferred nowadays is because of the better hepatocyte uptake, almost 50% uptake is there, and the excretion pathway is more towards biliary and renal, and it is a very short hepatobiliary phase compared to gadobinate dimeglumine, which is and was previously used wider than it is called multi-hands. The uptake is much lower, and its excretion is primary renal. So you will take more time for the hepatobiliary excretion to come. So for gadoxetate disodium, the time is around 20 to 30 minutes to hepatobiliary phase. For gadoxetate dimeglumine, the time is around 2 to 3 hours or even more. Minimum is 3 hours in many textbooks. Just to show you something, before 2012, there was another agent which is called mango trisodium. It is represented as manganese DPDP. Okay, it was called Tesla scan. It was having a high hepatocyte uptake, and excretion was primary through the biliary route. So this is withdrawn due to various complications and in homogeneity and all. So all these gadolinium-based contrasts which we discussed now are T1 contrast agents. So I would like to discuss about a T2 contrast agent also. So this is called super paramagnetic iron oxide. Okay. So this one is a T2 contrast agent. How it will look, I will show you in the next slide. So this is super paramagnetic iron oxide imaging. So what essentially we are using here is, this is actually a T1 routine, conventional contrast study of the same lesion, where you have a peripherally enhancing lesion with central non-enhancing area. Okay. So this is very inconclusive. We don't know whether it is a primary hepatic tumor or not. But when you do the SpIO2 imaging, all the area where there is Kupffer cells, means the normal hepatic parenchyma is there or hepatic cells are there, you will have black appearance because of the iron loading. And in the background of black liver, if you see a bright area like that, this what it says is this is an extra hepatic origin tissue. So this is one of the ways we can say for sure that that lesion is not a hepatic primary but a metastasis. Okay, a little bit about hepatobiliary phase MRI, how basically these things happen, how we are getting high signal in some of the lesions in hepatobiliary phase and how we are not getting signal in others. So this all are already discussed. Only thing to remember here is this for anion transporting polypeptide channel, or it is called or OATP1, OATP1B3, like all the non-people say, but this is new to me also. Then we have another called multi-drug resistant associated protein, MRP2. So what basically happens is, whenever you inject a contrast, both extracellular or intracellular, no, this is only for intracellular. So what happens is that this in the sinusoid, the gadolinium molecule will get transmitted into the hepatocyte through this OAT-P receptor. What happens is that in a normal uptake one, it after some time it gets completely excreted and the bile canaliculi, it will go like this. So in cases where there is hyper or overexpression of this OAT-P1B3, there will be more accumulation of the hepatocyte quantity of gadolinium. And in cases where there is fibrotic scar, what happens is that the expression of MRP will be affected and there will not be excreting it faster. It's supposed to be. So in these both conditions, in the hepatobiliary phase, you may get hyperintensities like this. So these are all varying hyperintensities. This is like a hyperintensity with a central scar or a scar appearance, varying hyperintensity, less hyperintensity in the center, ring-like hyperenhancement, or homogeneously hyperenhancement, nodule within an enhancing nodule appearance, or peripheral rim-like enhancement. So these all are different types of hepatobiliary phase appearance of various lesions, which we will discuss in the subsequent images. So you can take a screenshot of this as well if you want to go through it later. So now always the question comes, when to use this hepatobiliary contrast? See, we cannot use it conventionally because the problem is the cost. It is much costlier than the normal or the routine extracellular contrast agents of gadolinium which we use. So whenever there is a indeterminate study with extracellular agent, you can use this. And ideally, hepatobiliary MRI contrast agents are used when there is an atypical FNH versus a hepatocellular carcinoma in question. Also, when there is HCC or metastasis has to be differentiated, we can use this. And this also increases the sensitivity compared to other extracellular agents. Now, in LIRADS, the recommendation is in cirrhotic patients with prior history of hepatocellular carcinoma, hepatobiliary phases are helpful to identify carcinogenesis in hypervascular nodule or lesion. This I will explain when we discuss that in the actual slide. So now this is the second most question everybody asks is like, what is the protocol optimization for pediatric age? See, we are limiting ourselves with two things. One, the amount of time which the child has to spend inside the MRI machine. Okay. Second, we have to adjust the contrast in a way that the dose is correct and that whatever we have administered has come in the correct time. So with that in mind, we have to use faster sequences. And when you use those faster sequences, you have to use respiratory triggering. So this is in default, there will be there in most of the new generation machines, you can use it. So these are the sequences which is same, coronal T2 weighted fat suppressed or plain with fat suppressed. Fat suppressed is a must. In phase, opposed phase, axial T1 weighted fat suppressed pre-contrast. Then we will take a fat suppressed post-contrast images in arterial, portovenous and delayed. The difference is here. So in adult, the arterial phase starts at 20 seconds and finishes at 30 seconds. Due to the difference in the pulse rate or cardiac activity in the pediatric age group, all phases tend to be a little bit earlier. So we have to make that use. Okay, the acquisition has to be done this way. One good thing is, since we are doing continuous dynamic imaging, we will not miss it. But still, just to be sure of that. And you should use diffusion weighted imaging in all pediatric tumors, even if you are not using in adult tumors. But most of us use it for all tumors, right? We use diffusion weighted imaging in all cases. Now, coming to axial T1 weighted fat suppressed hepatobiliary phase, as I told earlier, there will be a slight early excretion pattern in these cases, especially if you are using gadoxetate disodium, ideally between 15 to 20 minutes. So coming to the tumor proper, I have a question to ask. You all can discuss or think about it. The first tumor is hemangioma. Are adult hemangiomas are same as pediatric hemangiomas? So the answer is no. Why? Adult hemangiomas are venous malformation. Those are not neoplasm. How? Histopathologically, when you assess the tissue, there is no cellular turnover. So the marker for cellular turnover is GLUT1. So it has to be GLUT1 positive to say that this is a case where you have a multiplication and you have more cellularity. Also, one important thing to notice, most of the hemangiomas, unless complicated, this is the word, unless complicated, remains the same from the time of detection for long years. Once it gets complicated, for example, hemangiomas can have internal hemorrhage, hemangiomas can go under in its own degradation, and sometimes assumed to become much bigger than it is. Okay, so because it's a venous malformation, there is always a chance for blood accumulation inside. Okay, so that is one thing. So we'll directly go to the imaging features. I will show you slides of different images. I hope the timing will be perfect. So we can start with ultrasound, as I told earlier. In ultrasound imaging, what will we see? We will see generally hyperechoic lesion in a background of normal liver. When you put color Doppler, the central lesion will not show obvious vascularity, but surrounding it, you might demonstrate some prominent vascular channels like this. And this, if this is not seen, then what you will see? You will see a hypoechoic area in a background of fatty liver. And how will you know this hypoechoic is like a benign or like a malignant? See the posterior acoustic enhancement here. So this represents that it is less likely to be a higher cellular lesion or anything. Then also the color Doppler, there is no internal vascularity. Now coming to the CT, as I told earlier, plain CT just to see for the calcification or hemorrhage, if any. Other than that, no much rule. This will be the same appearance of hepatic cyst also. This will be the same appearance of hepatoma also. We will not know what it is. But when you start to give contrast, like in the early arterial phase, you will see the classical peripheral place enhancement with centripetal enhancement filling in the photovenous and venous phases. And for hemangioma, if you wait till 10 or 15 minutes and then review it, even then also you will see the lesion is still enhancing and the amount of non-enhancing areas reduced significantly. This is how the classical presentation is. But in most scenarios, this is not classical nowadays. You will have an overlap of many things. Okay. So in MRI, this is one of my favorite photos. You have this light bulb sign. What is this light bulb sign? In a T2 fat suppressed imaging, on a background of the hypo liver, you will have a bright liver lesion. So this is how hemangiomas look on T2. And there are other variations which I will just briefly discuss. This is something called a flash hemangioma, where the entire lesion enhances very bright in the arterial phase itself, and it suddenly washes out also. So this becomes an atypical appearance, which we will address in other following sequences. Okay. Now, regarding pediatric hemangioma, what we are looking at is we have three different varieties of pediatric hemangioma. The focal hemangioma, this is almost resembling the adult hemangioma variant in all imaging modalities. You have a peripherally enhancing lesion in the liver, and it is only one lesion, and then it will slowly, progressively fill in the later phases. The differences between the focal, multifocal, and diffuse are, first is the age of appearance. So in the focal hemangioma, the presentation can even be in prenatally. So if you do an antenatal scan, if it is big enough, you can pick up in an antenatal scan as well. So in the association part, it is not associated with cutaneous lesions. Yes, it will undergo regression, which is one of the telltale features of all the pediatric hemangiomas. Pediatric hemangiomas will grow and then regress over a period of time. Regress means it will reduce in size over a period of time. So regression, yes, between first and second years of age, it will reduce in size. Multifocal hemangiomas, you will have all the same features as the adult hemangioma again, but more than two lesions, two or more lesions will be there. So these are not present at birth. It will grow rapidly in the first year and slowly involute over the next 5 years. So next comes diffuse hemangioma. So diffuse hemangioma, the problem is not with the tumor itself. The problem is with the extratumoral complications like cardiac failure and anasarca. Let's discuss a case on that aspect. So this is a case where a 2-year-old child with abdominal distension was evaluated. You can see the liver tissue is very sparse, and almost the whole liver is replaced by this T2 hyperintense and T1 hypointense lesions, which on contrast study And the arterial phase shows peripheral patchy enhancement. In the portovenous phase, you can see the progression of enhancement. And even in the later phases, you can see the enhancement becoming complete in some of the lesions. So this was again this is a diffuse hemangioma. In this patient, there was anasarca, cardiac complications because of the tumor load. Okay. Now, hepatobiliary phase in hemangioma, how it looks, T2FS, it will be hyperintense, of course. Then we have that patchy peripheral enhancement in the arterial phase, progression in later phases. And this is the clinch here. So in the hepatobiliary phase, the lesion will be fully dark. Like there is no hepatocyte inside a hemangioma. So there will be no retention or excretion of the contrast into the hepatobiliary region because there is no hepatocytes or biliary network inside the hemangioma. So this is how you differentiate with a large hemangioma versus a hepatic origin tumor. So coming to the next tumor, focal nodular hyperplasia, as I mentioned, even though it is reported in children, this is predominantly an adult tumor. So basically, it is composed of a benign appearing hepatocytes, more closely packed than normal liver, adjacent normal liver. So it will appear different compared to the normal liver. The classical feature or the most identifiable feature of FNH is a presence of a central scar, which will be T2 hyperintense on plain T2 weighted images. Without fat suppression also, it will be hyperintense. And one of the advantages of identifying an FNH and excluding all other tumors is that FNH never undergo malignant transformation. Also, the chances of growing the FNH becoming bigger by as the patient grows or as the years go ahead is less, almost less than 15 to 20%. Okay, so we'll just show in imaging with contrast. What we will see is we will see intensely enhancing periphery with a central non-enhancing scar in both CT as well as MRI. This is classical about FNH. And there is atypical FNH where there is absence of the central scar. Then the question becomes difficult. Okay, then we need to use additional techniques or modalities to confirm whether it is FNH or something else. Okay. So just to show how it looks in the hepatobiliary phase. So in the normal T1 non-enhanced phase, the FNH resembles the normal liver parenchyma. Of course, it has hepatocytes. The only thing is it is packed more. And in the enhanced phase, this is what you have to take. So in enhancement, the FNH will be the hyper of all the liver parenchyma. So in all the phases, FNH will be hyper. For example, in the arterial phase, it will be bright. In the portovenous phase also, it will be bright, even though washout is happening, but it will be still brighter than the adjacent liver parenchyma. And even in the hepatobiliary phase, it will be bright compared to the adjacent liver parenchyma. So there is retention of hepatobiliary phase contrast because of the presence of normal hepatocyte and the network. Okay. So this is how you identify a focal nodular hyperplasia. So as we know, even though everything is classical, there are reported cases of atypical presentations like hyperintensities in the center with peripherally placed capsule-like areas, and those capsules showing delayed enhancement with central mosaic attenuation. But these are all rare occurrence, not classical. Now coming to the next benign tumor, hepatic adenoma, rightly said as hepatocellular adenoma. So the importance of hepatocellular adenoma compared to the FNH is that this is a tumor which can undergo complications more, which can undergo more malignant transformation potential than any other tumor, benign tumor we have discussed so far. Okay. So most common association in adult population is females with contraceptive use or both sex with obesity and children with glycogen storage disorder or similar. Okay. So there are a total of 5 histological subtypes reported by various literature. The ones we should remember is the inflammatory HCA because of the chances for complications. And the second one we should remember is the beta-catenin mutated HCA because of the chance for malignant transformation and the atypical imaging, which resembles HCC in many protocols. So There is a combined variety called mixed, which has both beta-catenin mutated forms as well as inflammatory HCA. So there is another form called HCA without classical steatosis. So 3, 4, and 5 has more risk for malignant transformation. So the beta-catenin mutated one, HCA without classical steatosis, and the mixed beta plus inflammatory has high risk for malignant transformation. Among this, the mixed has the highest potential. So coming to imaging, this is a plain CT. You can see intraluminal or a positive contrast media given. There is no contrast in the arteries. So this is a plain CT. In the plain CT itself, you are seeing a hyperdense appearance in the liver. So this is clear evidence of hematoma occurring within the lesion, and the periphery is hypodense. The same thing, if you look here, this is ultrasound image. You would miss it as a kidney maybe because it looks like a kidney. You may even tell this as a pseudo kidney. But no, this is within the liver. And you can see the hyperechoic area in the center representing the hemorrhage and the hypoechoic area representing the lesion. Now, this is mentioned in few of the literature that if you do a color Doppler evaluation of the tumor, there will be, of course, increased vascularity both inside the tumor as well as around the periphery. But if you do a spectral tracing, if you do a, the waveform of the thing, it will be non-phasic, it will be flat. This has some amount of sensitivity and positive predictive value, according to few of the articles I've came across. So you can try this if you are coming across such a lesion. You can try to see this. Now, another presentation will be calcified mass, centrally calcified mass with irregular outline. This is also reported in most cases. And this calcification may be because of a previous hemorrhage. And in the arterial phase, it will show enhancement, good amount of enhancements, little bit heterogeneity is there. And the same for arterial phase in the MRI. The central area almost resembles a scar, but it is not a scar, it's a calcific foci. Okay. Now, hepatobiliary phase in hepatocellular adenoma. This is a T2FS image. Depending upon the varying content of the hepatocellular adenoma, it can be fat-rich, fat-poor. So if it is a fat-poor adenoma, it will be hyper. And if they're in the post-contrast phase, it will show significant enhancement this is one of the clinching part. In a classical hepatocellular adenoma, even though there might be hepatic cells inside, there will be no enhancement or retention of contrast in a hepatobiliary phase. So it will be hypo in hepatobiliary phase. So just to conclude this one, another case. So this is more an adult female, 46-year-old female with OCP used for many years. Here we are using in-phase and opposed-phase images. You can see there is no suppression. So first of all, it is not fat-rich. It is fat-poor. Intracellular fat is not demonstrated here. Second thing, you are in the arterial phase, it is showing heterogeneous enhancement. Even in the hepatobiliary phase, there is heterogeneous retention of the contrast with some heterogeneity in this. So when you see something like this is like a borderline lesion. Borderline lesion in the sense, one suspicion should be towards beta HCA because beta HCA has, varying fat content. So just to compare, I put a chart here. So inflammatory HCA, mostly hypoindence in the hepatobiliary phase, sometimes can take inhomogeneous uptake. Meanwhile, beta HCA can be hyperindence. Okay. And in the plain unenhanced images, there might be even a presence of central scar. Meanwhile, FNH will have its own features, which we already discussed, just to show the comparative appearance. Now, coming to the malignant tumors. So hepatoblastoma is the most common primary liver tumor of childhood, and it is the third most common abdominal malignancy in childhood, first and second being neuroblastoma and nephroblastoma in abdomen. And the median age of presentation is around 18 months to 19 months, so 1.5 years is the average age of presentation. And very rarely, almost less than 5%, it occurs above age of 4. Okay. And there is higher incidence in low birth weight babies, and especially in males, which has almost double than the female corresponding. So this is how a hepatoblastoma will look in a contrast study. Hepatoblastoma will have arterial phase hyperenhancement compared to that in liver parenchyma. and it will retain the enhancement even in the portovenous phase and somewhat even in the equilibrium phase. And the classical appearance is, since there is absence of the normal mature cells of hepatocytes or mature hepatic networks, there will be blackened appearance of the hepatoblastoma in the hepatobiliary phase. Another example here. So here we have a lesion, which is the hyperintensity on T2FS image with a central relatively lower intensity area. The same on T1FS post contrast, you can see the central area is still not enhancing while the peripheral area is showing enhancement. And in the hepatobiliary phase, there is no enhancement of the periphery with the central area showing the same hypointense appearance, representing a large tumor with central necrosis. So remember, hepatoblastoma can have calcification. Hepatoblastoma undergoes necrosis, and there will be areas of non-enhancement. And the enhancement in the hepatobiliary phases, majority of the times, it will be black, means hypointense. So regarding classification system, we have a system called Pretext classification system. So this is a system which is applicable for all pediatric tumors, not just the liver-based tumors, even for neuroblastoma, Wilms tumor, everywhere we are using it. The reason for this is, I am discussing this is one of the purest radiological classification systems which you can implement in your report, which will help the surgeon to decide whether or not proceed with surgery. If surgery, whether or not to do resection or transplant. So this is the only purpose of this pretext scoring. Okay. So pretext stands for pre-treatment extent of the tumor. So this has multiple steps. First is to assign a correct appropriate pretext score. It's from 1 to 4. Then step 2 is to check for vascular involvement. We are assessing the hepatic vein, portal vein. Hepatic artery is not necessary in these scenarios. What we are looking is either compressive obliteration or encasement of the vessel or intratumoral extension into the vein, like portal vein thrombosis or hepatic vein thrombosis. Additionally, we will have to put proper annotations like extrahepatic disease, rupture of the tumor, lymph nodal metastasis, etc. So coming to pretext classification, it's straightforward. There is no complex science here. We are dividing the liver into 4 portions based on the Coynard's anatomy. So 1, 2, 3, 4. If it is either involving the rightmost or the leftmost, it is pretext 1. If it is involving 2 subadjacent means closed areas, 2 subadjacent lobes, it is considered as pretext 2. If it is involving 3 subadjacent lobes, it is considered as pretext 3. And if it's a diffuse liver disease, it is considered as pretext 4. And if the lesion is affecting 2 separate but 2 lobes, for example, the lesion is affecting the right lobe as well as left lobe, it is considered as pretext 4. Why? Why we need to classify this like this? The presence of pretext 4, presence of elevated alpha fetoprotein, this is considered as a high risk group, and there itself it is omitted for any of the surgical interventions because there will be a high recurrence, high failure rate regarding the tumor. Okay, so all other is standard risk. Additionally, if you have any of the pretext 2 or 3 with any of the additional pretext criteria annotations. So regarding the annotation factors, we have these annotation factors: E, F, R, C, N, M. E for extrahepatic extension, F for multifocality, R for rupture, C for caudate lobe involvement, N for lymph nodal involvement, M for metastasis. And additionally, we should use V and P. V for non-portal vascular involvement. If portal vein is involved, mention it as P. We will discuss in few case scenarios in the upcoming slides. So this is how you determine. So I will just explain about this extrahepatic spread of disease versus lymph nodal metastasis. So extrahepatic spread of disease refers to when the lesion breaks the capsule, goes outside the liver, which is directly evident as a local invasion, or you see a peritoneal nodule or a peritoneal deposit. Okay. So how will you determine a peritoneal deposit as assessing factor is if there is at least one nodule measuring 10 mm or larger, or if there is a less than 5 mm nodule, you have to see at least 2. Okay, this is how we characterize it. And this is not lymph nodal metastasis. Lymph node means you have to see lymph node alone and it has to be categorized separately. And metastasis is again classified differently. You have to add additional annotation features. Coming to this lesion, what do you think the pretext score is? You see a very large lesion. So the tendency will be to think that it is more than pretext 3. No. So you have to trace or track the hepatic veins. So hepatic vein forms the landmarks for the division of the coinage system. So for example, left, middle, and right. So this is basically between the middle and the left hepatic vein. So this is still in the right lobe. So the maximum involvement is probably 2 segments or 2 areas. So this is pretext 2. And there is no thrombosis or anything. So it is just pretext 2. Okay. Now coming to this tumor, what do you think? We are having a diffuse infiltrative lesion, and we are having 1, 2, even these 2 lobes are affected. So at least 2 here and 2 here. So it's 4, pretext 4. Additionally, we are seeing hypodensity inside the portal vein. So this is a portal vein thrombus. So we have to put P. Then it comes multifocality. So you have to put F. So the score, like, it will be reported like this: pretext 4, PF, means portal vein with multifocal involvement. Okay, this is how you categorize. Regarding C, R, L, and E, C stands for caudate lobe involvement. How will you determine caudate lobe involvement? Caudate lobe involvement is like when you have a very large lesion isolatedly involving the caudate lobe. By default, it is pretext 2. If caudate lobe involvement is there, it alone, it is not considered as pretext 1, it is considered as pretext 2. So how will you identify a caudate lobe? When you have a lesion which is separating the portal vein from the IVC. So this is how we determine it. So this is the caudate lobe lesion. And this has a well capsulated appearance. So that means this is only compressing and displacing the posterior right, anterior right, and maybe the intermediate one. Now coming to this lesion. So what we are seeing is that this is a bigger lesion. There are at least 2 lesions here. That is 2 lobes here and 1 lobe here. So by default, it becomes pretext 4. Then on top of that, there is rupture. So what do you mean by rupture? Rupture means the lesion has gone beyond the outlines of the capsule. And how will you determine it for sure? You have to check the attenuation of the fluid inside. Sometimes it is hyper dense in CT itself, so it gives an idea there itself. Or else you see the outline like this. And then you have this fluid leveling inside MRI imaging, which can also give a more diagnosis for rupture with hematoma. Now coming to the later part, this is again caudate lobe lesion, but we are having an enhancing lymph node. So this is a metastatic lymph node. So even though this was a pretext 2 lesion, now with metastasis, it has staged up. So that is a hint here. So the last one here about extra hepatic involvement, we have a nodule here, which is also of more than 1 centimeter. So this has to be considered as extranodal peritoneal deposit with ascites. You have ascites and lesion also here and here. So coming to the next topic, hepatocellular carcinoma. First, we'll discuss about pediatric. So the main differences between a pediatric hepatocellular carcinoma and adult hepatocellular carcinoma is the incidence of cirrhosis. So very little amount of cases have predisposing condition in pediatric age group, and the predisposing condition itself is different. For example, the most common predisposing conditions are congenital anomalies of the hepatobiliary system in child. And then comes disorders like metabolic disorders like tyrosinemia. Then we have other disorders like cardiac causes. Then we have vascular malformation like Abernathy malformation. So all these things are part of the spectrum of predisposing conditions for children. Meanwhile, in the adult, the most common predisposing factor is cirrhosis, either plus or minus the presence of hepatitis B virus infection. So another issue with this, the survival rate is very less in child for hepatocellular carcinoma. So the early detection warrants better management. Now we have same as in adult, classic fibrolamellar and hepatocellular carcinoma otherwise specified. So classic hepatocellular carcinoma presents in the first decade of life, and there should be an underlying genetic or metabolic disease leading to the chronic liver disease similar to adult HCC. But in the fibrolamellar variant, most of the time there is no underlying causes, and the presentation is a little bit later compared to the classic variant. So this is again a question for the audience. Among these which case, these are two different patients, which case do you think has a predisposing liver disease? Is it the smaller lesion, the one with the smaller lesion, or the one with the larger lesion? So the answer is the one with the smaller lesion is the case which had a predisposition. So now you understand why the pediatric HCC is entirely different from the adult HCC and why LIRADS is not used in pediatric HCC. Okay, so the surveillance might have made it to be detected much earlier. Meanwhile, in this case, since there was no predisposing factor, the kid was evaluated for an abdominal distension. In both cases are of biopsy-proven hepatocellular carcinoma. And so this is the main difference here. So in hepatobiliary phase imaging of pediatric hepatocellular carcinoma, this is a classical picture. There can be variations. So in the T2 fat suppressed sequences, it should be a little bit hyperintense compared to the adjacent liver parenchyma. In the hepatobiliary phase, there should be non-peripheral, central or whole contrast enhancement with washout on the later phases, which should be also non-peripheral, should wash out. And sometimes in pediatric age group, the washout will be much faster also. And in the hepatobiliary phase, the classical hepatocellular carcinoma will be hypointense compared to the rest of the liver parenchyma. So this is how it looks. So this is one additional point I want to discuss here now. Very often we compare the plain with the arterial and the late phases for washout and all those things. Okay. So if there is not a complete washout in any of the tumors when you are doing an MRI imaging, please see the subsequent phases images also, because sometimes there will be a slight delay in the washout, but it will completely wash out on the later phases for hepatocellular carcinoma. This, according to few studies, will increase the sensitivity for detection for hepatocellular carcinoma while preserving the specificity. So this I already discussed before. Main differences adult versus pediatric HCC is predisposing factor, higher incidence of tumor presentation in the normal liver age group, and approximately 80% of the patients by the time of presentation. You know, the LIRADS, the size criteria is less than 2 centimeter, more than 2 centimeter. Majority of the pediatric tumor at the time of presentation itself will be more than 4 centimeters in 80% of the cases. Meanwhile, in adult population, it is around like 50 to 60%. So this is another interesting article where you can read about the hepatocellular carcinoma imaging features in cases with and without underlying risk factor. The summary is this: patients who had underlying risk factors presented with relatively smaller tumor compared to patients with no underlying risk factors. So that is the point of the whole study. They have given percentages and all those things here. And higher complexity is also more common with patients who had no no predisposing factors. So what does it say? It says two things. One, in cases where you have a predisposing factor, yearly surveillance or regular surveillance can enable us to detect appearance or presence of a malignancy in a child group and manage it appropriately as soon as possible. So that's the only thing they want to stress here. So that is the point of early surveillance, is to enable early detection and resection of the tumor whenever possible. As a general consensus is that with the predisposing risk factors for HCC in the pediatric age group has lower pretext score in general and hence more practically resectable if possible. So this is what the study concludes. Now, just to summarize the pediatric tumor. So benign, we already discussed congenital and infantile hepatic hemangiomas, mesenchymal hematomas, we didn't discuss, focal nodular hyperplasia, hepatocellular adenoma, and then malignancy like metastasis, hepatoblastoma, HCC. The one thing I put this is for the age group. So depending upon the age group, so I told earlier, the classification you should follow is the age. So when you have a borderline lesion, you can put at least two differential of the similar age group. In this particular case, you can, if you feel like it is hepatoblastoma, it should be less than 5 years. More than 5 years, 10 to adulthood, then you should put a differential of hepatocellular carcinoma, especially if the imaging features are not fitting into one set or not classical. So this is a summarizing chart. You can take a screenshot here also if you want. and hepatoblastoma, hepatocellular carcinoma, cholangiocarcinoma, undifferentiated embryonal cell carcinoma, angiosarcoma. This is categorized on the basis of the incidence. Highest incidence hepatoblastoma, very low cases of angiosarcoma, less than 50 cases, as so far reported in the literature. So all these things has to be in consideration. Some imaging features, classical imaging features. So one is hepatoblastoma, the heterogeneous mass. Cystic appearance is common, calcification is common, can have intra-lesional hemorrhages, possible necrosis. All these are common. And hepatocellular carcinoma, the classical one will resemble exactly like the adult, non-peripheral central arterial enhancement, non-peripheral washout, like they have a good washout with presence of capsule and all other features. Now coming to the next topic, LIRADS. With this, we will discuss the hepatocellular carcinoma in adult, and then we will conclude. So LIRADS, this is a brief overview. It's already available. Most of you have gone through this. So LIRAD basically represents liver imaging and reporting data system. So basically, this is meant, according to the LIRADS team, they have mentioned clearly, this is meant to follow or screen patients who are a known case of liver cirrhosis and chronic hepatitis B virus infection without cirrhosis. So this is the main purpose of LIRADS. So it gives us a probability or a chance, low to high chance of probability of HCC, or even some tumors which are non-HCC can be picked up in this way. So LIRADS should not be used in patients less than of 18 years. Also, in patients with cirrhosis due to congenital hepatic fibrosis or due to vascular disorders, because enhancement, pattern of appearances, all things changes. So if you evaluate younger patient or patients with predisposing factors mentioned here, the appearances will be different. So you might get a wrong LIRAD stage. So that's why they recommend not to do that. Okay. So this is again a very good article by Gary R. Schooler. You can check online. This one is also interesting to read regarding LIRADS, and they have compared many studies together. Okay. So coming to adult HCC, 80 to 90% of the adult HCC develop in cirrhotic patients. Most HCCs show hyperintensity in hepatobiliary phase. Okay. So this is an ancillary features of LIRAD, and most HCC showing hyperintensity on hepatobiliary phase. The pattern of hyperintensity may be either homogeneous or mosaic or nodule within nodule. Okay. The most common being homogeneously hyperenhancing in the hepatobiliary phase. This is not common, but it is seen. Of that, this is the nodule within nodule type of enhancement. I will explain a bit why it is important. So, for example, when you are screening a patient over a period of time with a patient with cirrhosis, he has multiple hypovascular or hypervascular dysplastic nodules in his liver parenchyma. Suddenly, one of the hypovascular nodule which you are screening suddenly develops in a nodule within nodule enhancement pattern in a hepatobiliary phase. This is itself one of the signs of neocarcinogenesis or hepatocarcinogenesis. Okay. So this is what importance is about this phase. Now regarding LIRADS, there are major features and additional features. So major feature is arterial phase enhancement. It should be more than adjacent liver, and it should be non-peripheral type of enhancement and non-peripheral type of washout. Okay, in the later phases. Capsule should be there. It should be either fully surrounding or partly surrounding the lesion. So just to show you, very small lesion here. Arterial phase shows significant enhancement. In the portovenous phase, it shows washout. And in the hepatobiliary phase, it shows somewhat similar appearance to the liver parenchyma, but it is not hyperenhancement, and you can see a capsular appearance of hypointensity. Okay. And another mentioned project is like this. If you are suspecting hepatocellular carcinoma and the lesion is the larger or becoming larger over a period of time, it's a high chance to be hepatocellular carcinoma or a malignant tumor. So this is the one I explained earlier, nodule within nodule type of enhancement in the hepatobiliary phase. Again, a telltale sign of neocarcinogenesis. This just to show you how it looks in CT, same enhancement, and delayed there is washout. This is another atypical appearing area with calcification also is seen in some scenarios. Now coming to Steps of assessment of LIRADS. We will move a little faster here. So LIRADS, we have categories from LR1 till LR5 and additional categories like LRTIV, which means tumor in vein, LRM means malignant but not HCC, and LRTR means treated mass. Okay. So how you start to evaluate is first and foremost thing, identify the lesion, check for the type of enhancement. So in the arterial phase, if the lesion is showing hypo or iso enhancement, it is very less likely to be HCC. So if you can look at here, even with the addition of the additional features like enhancing capsule, non-peripheral washout, and threshold growth, with at least two of this, the maximum stage it can go is LR4. Okay. But when the size of the lesion becomes bigger and there is arterial phase non-REM hyper enhancement, then the staging goes higher. And if there is +1 or 2 or this one, it can be up to LR5. That means very high chance that this is hepatocellular carcinoma. So just to discuss about the LRTIV, the tumor in vein, what it says is that when you have a non-enhancing curvilinear area inside the hepatic parenchyma, which is persistent in arterial and as well as portal phases, you should think about, intravenous or intravascular thrombus. So this can be also demonstrated in MRI as diffusion restriction. And this will progress in the follow-up most of the times if the treatment doesn't work for these cases. So what does it signify? So LRTIV, if it is picked up and you write like LRTIV, that means it is a non-resectable or surgical option is out of the question now for this case. So that's what important about this is. Now coming to LR malignant category, LR malignant means that it has non-typical features of hepatocellular carcinoma. Means it doesn't fit into the classical imaging appearance of hepatocellular carcinoma, but it has features of malignancy in the imaging, like diffusion restriction, maybe capsular invasion, maybe extravasation. All those things are there, but it doesn't fit into the classical imaging description of hepatocellular carcinoma. Then in that cases, we mean that this is malignant, but it is not hepatocellular carcinoma. But in imaging, whenever we have given that, at least 2/3 of those cases have come back as non-HCC malignancy, or the other one came as combined malignancy like cholangiocarcinoma plus hepatocellular carcinoma, something like that. Okay. Only 5% of the lesions, according to various studies, have come back as benign when you give us LRM or LR5. So this is the efficiency of the LIRAD system. It is still being modified, but the last update came around 2019, so it's still being followed. Now there are some ancillary features. We'll just go through the images. So in some lesions, what we will have, there can be intralesional composition change, like intralesional fat in the mass, like here, and there can be intralesional hemorrhage, very common, or there can be non-enhancing capsule, or there can be nodule within nodule appearance, which can be seen in any of the phases. Okay, and in some cases there can be even mosaic architectural appearance. So this just to show you how it looks. Small lesion in opposite phase, you can see signal suppression in the opposite phase. So then in the arterial phase, there is hyper enhancement, which is non-central, non-peripheral, almost homogeneous enhancement. Then there is a non-peripheral washout in the later phases or the photovenous phases. So these all things are more in line of hepatocellular carcinoma. Now, application of LIRADS as similar to all other RAD systems which we use in imaging. Up to LR2 is considered as benign, and LR3 is like a marginal or borderline lesion. So we have to do short interval, either short interval or long interval follow-up, depending upon the size and other parameters. And in cases from 4 to 5 and LRM, which needs MDT workup, like you have to put a tumor board in and then discuss and then decide whether go to biopsy or process accordingly. Okay. Now, coming to the protocols, so the required images for CT are late arterial, photovenous, delayed phase, already mentioned, and pre-contrast images are recommended, especially after loco-regional treatment, like when you do a partial resection, or you do, the embolization or similar processes, you can use pre-contrast images as well to determine. Then unenhanced MRI, we are using the same protocol. Hepatobiliary phase is the recommended choice for LIRADS to image all these tumors and further characterize. And the current recommendation is for gadoxetate disodium in wherever it is available. Now, lastly, just briefly about cholangiocarcinoma. Cholangiocarcinoma is like more towards the adult age group of the later decades, like more than 40 years of age. And even if in the children, it will be seen very rarely, but also towards the later decades of childhood, like in the teens, something like that. And in child, one thing to note is cholangiocarcinoma is even less than 1% of the whole focal liver lesions, not just the tumors, whole focal liver lesions. So that is the rareness in child age group. So some people with underlying risk factors like choledochal primary sclerosing cholangitis, all these are like congenital or early childhood or acquired ones. So these will keep on progressing and they have higher risk for developing cholangiocarcinoma. And there is also incidence with radiotherapy related. So it is subcategorized as mass forming, periductal infiltrating type, and intraductal type. So how it appears is irregular peripheral enhancement in the hepatic arterial phase with somewhat gradually centrally filling contrast enhancement. And the class feature is the contrast enhancement will still persist in all phases, even in the hepatobiliary phase like this. So this is a lesion here. You can see predominantly hypointense lesion. Now in the hepatobiliary phase also, you can see a periphery of non-enhancement followed by a cloud-like enhancing area in the center. This is somewhat typical of cholangiocarcinoma. Okay, this is referred as target sign in one of the articles which I read. They refer as this as EOB cloud enhancement. EOB cloud enhancement means hepatobiliary phase cloud enhancement. So this is again a picture diagram for you to look at. So this is taken from the article called from American Journal of Radiology, Hepatobiliary MRI Contrast Agent, Pattern Recognition and Approach to Pediatric Focal Hepatic Lesions. So what we have here is like, I will just go through some parameters here. So white means hyperintense, black means hypointense. And white with black means here like this is rim hyperintense with center hypointensity. So when you explain the hemangioma, T2 hyperintensity in both T2 as well as T2FS. And before contrast administration in T1, it will be hypointense. We saw it already. And in the arterial phase, there will be peripheral enhancement, slowly progressive filling as we discussed. And hepatobiliary phase, depending upon the content, it should be hypointense generally, or sometimes there can be peripheral enhancement, or it can be hyperintense also in some scenarios. So similarly, the one thing I want to discuss with you is the appearance of regenerative nodule and dysplastic nodule. So regenerative nodule and dysplastic nodule is somewhat isointense or subtle hypointense on T2 weighted images on liver. And before contrast administration, dysplastic nodules in T1, if there is central hemorrhage or similar changes, it can be hyperintense in dysplastic nodule, but again hypointense on T1. Post-contrast study arterial phase, no enhancement. Same here also, no similar enhancement. And hepatobiliary phase, the regenerative nodule will resemble the liver. You cannot differentiate it from the normal liver. Meanwhile, the dysplastic nodule will be somewhat, because of the slower excretion of the hepatobiliary concentration, there can be a little bit hyperintense appearance, or it will remain the same. Okay, coming to the malignant tumors, we already discussed all these findings. So with this, I will like to conclude. The take-home points of today's discussion will be UST should be considered as a screening modality for follow-up, and somewhat characterizations can be done using contrast-enhanced ultrasound whenever you are able to use it or you are expert in that. And in scenarios where you can avoid plain CT in children, please avoid it. Use MRI instead. And when you are using MRI, please use hepatobiliary phase contrast if it is available. Especially, it will give you additional data for characterization. And in pediatric hemangioma is not a tumor. Pediatric hemangioma is a tumor. Adult hemangiomas are venous malformations. Pretext score is mainly for screening for pediatric hepatoblastoma and liver tumors, but you can use it for assessing pediatric hepatocellular carcinoma also. LIRADS is for high risk versus low risk stratification alone in hepatocellular carcinoma in adults. So just to show you why this is very important, you have to implement all these things in your studies. See, if you take whole tumors over the last 25-year data, it's between, I think, in the 90s till the early 2000s. So you have seen majority of the mortality rate has come down for almost all the tumors. Meanwhile, liver and bile duct malignancies, the mortalities have increased for both sex, female and male, almost 60%. So this again signifies the need or the use of a proper screening algorithm or a screening technique to evaluate for all risk patients. So that's how LIRADS is being implemented. That's how Pretext is being implemented in liver tumors. So with this, thank you guys. I finished it. So these are my references. A disclaimer I have to make here is all the images are from either any of these journals, because hepatobiliary phase, unfortunately, even in my place here, we have a very advanced machine, very advanced department, but hepatobiliary phase usage is not approved for our hospital here in Qatar also. And in India also, I think very few centers use this nowadays. But even without that, with routine imaging, hepatobiliary imaging, you can go across all these things. So hopefully you can implement some of these things we discussed here today in your practice. With that, I would like to hand over this to the organizers team for discussion and further activities. So this is the Interventionist RAD group. You can just scan your phone or take a screenshot and scan this. You can join me there. I put weekly one case, interesting case, of course. So that's it.
It was a very, thank you so much, Dr. Arif. It was really an excellent talk covering all the lesions in the liver, which is very important because for the examination, at least for long or short case, we keep hepatocellular carcinoma and we ask the students how it is done, what's the amount of contrast used, what is the timings, all these things we ask and how we differentiate between the other tumors, all these are asked. So one thing that is you have just told everything about the as an intervention radiologist. I think you can just add a point on how do you approach to a case of hepatocellular carcinoma by doing TACE or tear.
So see, the problem with TACE and tear is hepatocellular carcinoma. Even if you have a very small lesion, which is typical of TACE, we pull on biopsy, everything is confirmed. The chance of failure is very high.
I know.
So the only curative modality, according to many researchers, many studies, they say is surgical resection, whenever applicable. Other than that, with TACE, if the lesion is very small, you have a not with TACE, tear and the other one, we can do a intervention there. But chances of recurrences are high because of the other associations involved.
Good. Okay. Now, just I wanted to add a point. That's why nothing else. And it was a wonderful talk, and you have demonstrated pictures also beautifully. The classifications, the pretext groups, everything was very good. The LIRADS. You have just covered the topic fit for writing an essay or attending a long case or a short case. It was very good.
Thank you.
Thank you so much, Dr. Arif, for being with us. From overseer, giving a talk is not so easy. It is difficult, I know. But still, you came with us and you were with us for Kerala for at least nearly 1 hour, 10 minutes. Thank you so much. On behalf of Kerala IRIA, I thank Dr. Arif for being with us for 1 hour and all the delegates who are listening to talk and the Clarinet team for giving the platform. Thank you so much. Thank you.
Thank you. Thank you.
Thank you so much to all the entries present here. And it is really glad to have all these million people together in the session today. Thank you so much for extending us the opportunity to host the session, and I hope you all had a seamless experience. So with
Thank you.
everyone's permission, I'm concluding the session in here for today and looking forward to hosting you again. Thank you
Thank
so
you.
much. Thank you so
Thank you,
much.
ma'am.
Good
Thank
night.
you.
Thank you.